Continuing with gastrointestinal disorders, emergencies. Dr. Hargraves. Surgical emergencies. I'm going to go mostly from the beginning of the GI tract down towards the end of the GI tract with emergencies that require surgery. Gastrointestinal bleeding. So if you look at the graphic on the right side, first, you don't need to know all of those. It's just showing you the anatomy and all of the different places that there can be bleeding. This is not specific to children, so I'm going to talk about the parts that are specific to children. Some of these are significantly more related to adults. But when we think about GI bleeding, we think about what's the pathophysiology? Where is the bleed coming from, and how can we tell where it's coming from? Well, if it's upper GI bleeding from the esophagus or the stomach, then usually there's vomit, and it either has kind of reddish blood, which would mean more likely the esophagus, or coffee grounds from the stomach. In kids, esophageal bleeds are pretty rare, so significantly, definitely not very common. So you won't see that as much as you see in adults. Lower GI bleeding, if it's bright red rectal bleeding, it usually means it's towards the end of the GI tract, or it's a really significant bleed that's bleeding pretty quickly. And then tarry stools, or called melena, that's indication of kind of partially digested blood. The most important thing, so when we're looking at GI bleeding, we're looking at a graphic on the right side here that shows many of the most common places for bleeding. You do not have to know all of those. I'll talk about the ones that you need to know for surgical emergency. But if it's an upper GI bleed, then the blood is most likely going to be vomited out, and it would look like coffee grounds if it's coming from the stomach, or in the rare case of an esophageal bleed, because it's not common in children, it would be more bright red or reddish colored. Lower GI bleeding, again, it can be bright red. That's if it's near the end of the GI tract, so in the rectum there, or if it's a pretty massive bleed that's putting out a lot of blood. Otherwise, it would look like tarry stools or melena, which is kind of dark black kind of stools that have partially digested blood in them. The thing to think of as a nurse when there's gastrointestinal bleeding is how much blood is coming out. So being on top of assessments, paying attention to the blood pressure and the heart rate, and watching those, because again, these come out through a sphincter, through the anus, which means that it's not like a wound on the body that's going to continue to bleed and you're going to see it. This means they could be bleeding internally and then suddenly poop out a whole bunch of blood. So gastrointestinal bleeding. So first, there's hopefully some diagnostics to try and figure out where it's coming from. And then again, it's watching the bleeding and the hemodynamic stability of the patient and assessing how much blood was lost. In pediatrics, we typically will just weigh things. So they might be on a chucks or some kind of a plastic kind of thing that we'll just pick up, and we'll weigh it on our scale and see how much blood is in there, or into a diaper. Nursing care management is really about assessment and emergency care. So making sure they have an IV that's functioning well, giving them IV fluids, maybe giving them packed cells, giving oxygen because they're losing red blood cells, suction if it's severe, and supporting the family while we're getting the child ready to go, usually off to the OR. Hypertrophic pyloric stenosis. Okay, so now we're up at the top of the GI tract. This is the sphincter. We talked earlier about the esophageal sphincter at the base of the esophagus. This is the sphincter at the base of the stomach. And it is the one that opens up when the stomach squeezes to allow food to go down into the intestines. This shows up with symptoms at 2 to 4 weeks, and the symptom is projectile vomiting. And I mean projectile. This isn't a wet burp or where the kid burps and it spits over the back of your shirt. This is where the kid projectile vomits out 2-3 feet out in front of them. And that's because when the stomach squeezes, the pyloric stenosis doesn't open, and so the stomach squeezes and it pushes the feed back out. These kids are hungry. They are fussy. They start to look, they're anxious first because they're really hungry and they're looking for food. And then if it goes on long enough, then they show significant signs of dehydration. You might see an olive-shaped mass in the right upper quadrant, so kind of where the base of the stomach is. And you can sometimes you can see a gastric wave across the intestines as they're trying to propel food through the GI tract, except there's not much food there. We admit these kids into one of the acute care units, usually, sometimes the ICU, to get them ready for surgery. They'll need IV fluid, and they usually need some electrolyte replacement, get them some dextrose. As soon as we start getting dextrose into them, they're pretty happy because they're getting, food to their cells. And then typically the next day they'll go to surgery, and it's not a super complicated surgery. Malrotation with volvulus. This is a congenital defect, and it happens in the fetus when the intestines don't rotate correctly in the abdomen, and it leaves a part of the bowel so that it can twist on itself. And it's called malrotation with volvulus. This will obstruct the intestine and cut off blood supply and allow bacteria to start eating away at the tissue. So we do emergency surgery to avoid bowel necrosis and or death. So then we send them to the radiology where they'll do a barium and air enema. And just sometimes by the pressure of the barium or the air, it actually reduces that intussusception, so untelescopes it, and then we don't have to do surgery. But if they do need to do surgery, it's diagnostic on the barium and air enema, and then they take them to surgery. And again, it's an emergency because we're going to have necrotic bowel. Next, we have appendicitis, which I know you're familiar with in adults. So same symptoms in kids. The abdominal pain starts in the periumbilical area, so around the belly button, and migrates to the right lower quadrant. They usually have a low grade temp, so this isn't the 102 temperature. This is 100.4 to 100 and almost 102. They'll have nausea and vomiting, and then they'll draw some labs in the ED. The CBC will show elevated white blood cells, and then they'll typically nowadays do an ultrasound. And on ultrasound, they're looking to see, does it look enlarged? That's what they can see, right? They can see shapes. A lot of the patients they're still operating on for appendicitis, the appendix looks fine, even though they have the other signs, but they'll go in and operate anyway. So then they have surgery, and then they'll be on some antibiotics. In kids, we usually keep them for a day, and then send them home the following day. That's what we typically do. If it happens to perforate, though, that means that appendix that's necrotic there, that's got stuff stuck in it and has bacteria growing, and if it pops, you can imagine it's going to spread across the abdomen there. So what that causes is a significant decrease in pain. They don't have this sharp pain anymore, and it changes to kind of this generalized abdominal pain, and they'll have decreased bowel sounds. Our goal is to do surgery before it perforates. However, if it perforates, then we need to do post-op care for a ruptured appendix. Now, these kids are going to be in the hospital usually 10 to 14 days because now they need long-term antibiotics, because when something seeds itself across the abdomen like that, the bacteria will grow in these little pus pockets, they're called. So they'll come back if they go to surgery, which it depends on the hospital whether they go or not. ATI says take them to surgery, and I know that our general surgeons did not take them to surgery. Our general surgeons admitted them to the unit and put an NG tube down because their intestines have basically stopped. It's kind of this shock to the whole system. And then, so they have an NG tube that's going to drain a bunch of yellow greenish stuff. And when that volume of that starts to decrease, then that means the intestines are working again. And then we'll start them on ice chips. That usually takes about 3 or 4 days. What we would do though is send them to interventional radiology. So they'll go there every couple of days, and they'll do a scan, and they'll see if they can find pus pockets. And if they do, then they do a little stab wound. They do a little incision and a wound, and they insert a drain into where that pus pocket is. Because if they don't, it just stays there, and sometimes it continues to grow, or sometimes it gets loculated, so the body builds like this hard thing around it. But it's best if we can get it out. All right, then we'll talk about um, incarcerated hernias. So I've mentioned hernias before, I think, and what's important about hernias is that you can push back the intestine back in through the hole in the muscle. That's the goal. And if it can't be pushed back, or it's painful or red or swollen or hot, then it means it's incarcerated, and then they need to have surgery because that essentially again causes necrotic bowel. So that's incarcerated. I'll show you on the next slide what we do, the surgery they do. Also, if a child has a hernia that's not going away, they tend to repair them before the kid starts to walk. So somewhere around 8 to 10 months or so is when they do this surgery. So here's a surgical repair. Those are various places that you can get a hernia, but we're showing the inguinal one, or the kind of this low abdominal one, and they put a mesh patch on it. So if you could hang on to the term mesh patch, or something that makes you think of, oh, it's going to be this patch of like a Dacron patch like they put on the hearts. It's this patch that they put on the inside, and it's just going to stop the intestine from going through, but you can't always sew the muscle back together. So that's the typical repair. And then testicular torsion is, you can see, sorry, we're in Spanish here. So antes is before or with the testicular torsion, and después is if you can fix it, or if you can't, then they'll do surgery. It's where the testicle gets twisted on the spermatic cord, and it's more common in children 10 to 14 and in infants. So if you think about kids who are 10 to 14, and what kind of things are they doing? Remember, this is our school age kids to adolescents, and they're usually pretty active. So this is where kids are wrestling, and they're fooling around with friends, and they're mock fighting, and they're playing soccer, and they're not always wearing a jock strap to keep the testicles up close to the body. But this is where the testicle just kind of spins inside the sac. It will cause a sudden onset of pain, nausea, vomiting, and then it looks swollen and red and taut. And so they'll try and reduce it. If they can't reduce it, then they'll take them to surgery.